This is an area where we have just started to look at what we can do in the consortium. So traditionally, the consortium has been about studies of etiology or risk factors. And a lot of those studies have been completed. So one of the next questions where we have a lot of potential to pursue interesting studies is for survival. It's also an area that matters a lot to patients, of course. But traditionally, survival studies or outcome studies are characterizing tumor markers and looking at how the tumor varies and how that relates to outcome. But another area is how the host characteristics are associated with survival. For example, we really know in the clinic that if you have other diseases, that will affect your outcome independently of what the tumor looks like. So it's clear that we have to consider also not only the tumor but also the patient characteristics. And that's where the InterLymph Consortium comes in, because we've been now for many years collecting data on host characteristics like germline genetic variation, the genetic makeup that you're born with, and lifestyle factors and occupational factors. Do you smoke? Do you drink alcohol? Do you suntan? And how does that affect your survival? It's clear in so many ways that we need to have bigger sample sizes to get robust results, because in separate smaller studies, a lot of the results can be driven by chance or different sources of error, and by pooling and by validating each other and looking for consistency of results, we will get much further. So that's one thing that we get more data to work with. And also, of course, the exchange of ideas and the exchange of interpretation of data is very important. And also, I think the consortium offers a unique environment to study host characteristics and prognosis, because clinicians or clinical researchers typically are very focused on tumor markers, as I said, so they haven't traditionally been incorporating host characteristics in their prognostic scores and things like that. So I think we can add something new. Of course, it has to be incorporated with all the clinical tumor markers and disease spread and everything. So I look forward to taking what we find into the clinical world and finding a way to integrate different prognostic factors. Depends a bit on what we find and how well we can do our analyses, and we need to enrich our data with the clinical data. So we only have that partly for now, but we have to look to add that and get the clinical data. And that's crucial for being able to sell the results, I think. But I'm quite confident because I'm myself from the clinical world, so I have the possibility to bridge over the two worlds, I think, which I hope will help. Well, I think that several studies have shown so far that current smoking is associated with a worse prognosis in lymphoma and lymphoma subtypes, and I think there's more to learn from that. For example, we don't know, it's smoking at diagnosis does seem to be associated with a worse prognosis. So the next question is, does it help if you quit smoking before you're treated, for example? That we don't know. One would assume that could potentially help, but that needs to be investigated in order to approach patients and give advice on that. But I think that's a factor that has not been recognized enough so far in the clinical world. So there have been some studies in a totally different area of surgery, where they have had intervention studies. So if people quit smoking before surgery, they do get less complications and a better survival. So one could ask if the same is true for patients going through chemotherapy, that potentially they could have less infectious complications. And so I think that's an area of great interest. And another hot topic also in many regions is the fact that low socioeconomic level has been associated with worse prognosis, and that also needs to be clarified what it is. Is it that patients with a lower socioeconomic status do not or do seek medical care at a more advanced stage? Or is it that they do not get the exact same treatment, or what is it? So there's more to learn about that also, to be able to give advice and modify treatment schedules. But that's another important area, of course, and that we feel strongly about that in Sweden, since we have a uniform healthcare system and we aim to give the same level of care to everyone.